Gosh. Where is my thing? Okay, so hi everyone. Thank you for coming to the NCL Nursing Forum. So my name is Tanya. I'm a practice nurse, Borough Barnet, and the lead nurse for Barnet and NCL Training Hub. So our agenda today, we have a talk on the breast screening pathway, which is delivered by Joseph Dale and Lucy McLaughlin from the NCL Cancer Alliance, but I will let them introduce themselves properly in a short while. And after them, we will have our newly appointed professional nurse advocate, Claire Dorrington. She will introduce herself and let you know what the PNS can offer you. This will be then followed by Anissa Tanner, our Senior Project Manager for Primary Care Nursing and Nursing Associates. And she will be sharing with you the recent evaluation of the professional nurse advocate role. And then lastly, we will have a very short Mentimeter, kind of seeking your feedback on of these monthly NCL nursing forums and kind of what else would you like to see in the future forums. However, before we kind of start on all of this, I would just like to give you a quick update on the wonderful day, GPN Celebration Day that we had last Friday in Regent's Park. It was organised for all of the GPNs across London for the third year running. I thought it was a great day. We had it was full with nurses kind of meeting with old friends and making new ones. We had some fantastic inspirational talks, great CPD sessions. And to top it all off, lovely food in fab surroundings, and the weather also behaved itself. So that was a bit of a bonus. The CPD talks, for example, were including things like COPD and sustainable inhaled therapy. Then we had a short talk about cancer and what that means to GPN training, GPN roles in them. Then it was understanding chronic insomnia and the management of it. We had a CPD session on cardiovascular disease and CKD. And then we had a lovely surprise at a great session from lovely Jane Chirini coming and telling us, or giving us a bit of an update in how to stay updated in travel. The inspirational talks that we had were on leadership. And Louise Reddy came and spoke to us about making nursing visible and count. And we had the Q&I coming and telling us how they're supporting GPN education and practice. So kind of all in all, we had a fantastic day out. And for those of you who have never been, I would wholeheartedly recommend that you put into your CPD diary for the next year to come and join us all and have a fab time with all of us. And before I kind of now just hand you over to our speakers, I would just like to remind you that of some of the CPD that we have kind of in the next few weeks. Now, no nursing forum and no CPD kind of in August due to all the annual leaves, but we are in the back scenes working on arranging flu and COVID update with Helen Donovan, and we don't have any set dates yet, so kind of watch this space. We have 2-day fundamentals of immunization that's coming up now for those new to practice nurses who have not had this training done yet. Day 1 is on the 24th of July of 24, and the day 2 will be on the 30th of July. I'm sure that Barbara's going to put all those links into our chat. Then what else we have? A vena puncture and cannulation on the 17th of September. Then we have introduction to asthma on the 23rd of September and introduction to CPD on the 30th of September, pardon me. And we also have, I would like to point out that the deadline for the application for the legacy mentor support has been now extended to the end of this month. So if you do have anybody who needs some support and a legacy support nurse, please do let us know, and we can kind of start organizing these things and getting the support that you need. So now I will then hand you over to Joseph and Lucy to give us their talk on breast screening pathways.
Thank you. If you bear with me one moment, I'll just pull up some slides.
And while you're doing that, Joe, shall I introduce myself?
Yes.
And then hand over to you?
Yeah.
Perfect. So I'm Lucy McLaughlin. I've been working in the cancer system since 2018 here in North Central London. So some of you may know me and some of you may not. I'm head of cancer commissioning and I sit within the Cancer Alliance, but I also have a remit to the ICB. And we're really grateful to be able to come here today. We really just want your views and thoughts on the piece of work that we are leading, and just really get your expertise and make sure we're considering all the aspects that will potentially have impact in primary care and for primary care nurses in particular. So I'll hand over to Joe.
Thanks, Lucy. And just to introduce myself, I'm Joe Dale. I'm a program manager in the North Central London Cancer Alliance. I work in the commissioning team with Lucy. I do that because there's only two of us, so it's a team of two. And amongst other programs, I'm leading on the breast hormone pathway program. So yeah, thank you for having us here today, and thank you, Barbara, for getting us onto the agenda as well. So what I thought might be useful is just to go through some of the background of how we got here, the aims and objectives of what we're trying to achieve, and then go on to discuss what we've done so far, basically, and then we can sort of open up and hopefully get some feedback, some comments, some questions from all from the group. So, yeah, in terms of the background, you all know that the treatment of breast cancer often involves patients going through radical radiotherapy and other patients with metastases who receive regular hormone injections. So they may be injections of goserelin or leuprolin or some other agent. The current administration practices across North Central London for these injections are very variable. So in some boroughs, there's trusts where the patients come in and they receive their hormone injections, and they do that on a monthly basis, and they're always seen in secondary care. Other boroughs were administering the first injections to patients and then discharging patients to primary care, where the patients would then attend primary care on a monthly basis to receive their monthly injections. So there's a bit of variability there. It's also a bit of an issue because treatment or administering of the injections wasn't a commissioned pathway for primary care to do. So on the 29th of August last year, there was a letter that went out from commissioners to providers and to primary care with regards to those patients who were being discharged to primary care, highlighting that it wasn't a commissioned pathway. And from that letter springs this sort of program of work where we're looking to develop and implement a single model for delivering those injections across North Central London for breast cancer patients. There was something similar, a similar program in place a year or two back for prostate cancer. So we're echoing sort of a similar process for breast cancer patients. So I won't go through all the objectives here, but you can see them on the screen. But yeah, we're just sort of aiming to enhance that patient experience by streamlining the approach, streamlining the administration process as well where possible, while still allowing for some flexibility and adaptability for any advancements we want to make to the pathway in the future. So back in February and March of this year, we set up a working group to review the current practices, identify where those variations are taking place across North Central London, and to start to develop that standardised protocol and that standardised pathway for administrating those injections. So we've had, I believe, 4 working group meetings so far. We've got a 5th one this afternoon after this meeting. We do have some representation from practice nurses and GPs and primary care and the LMC on the working group, but we were aware that previously we probably haven't engaged with practice nurses as much as we'd like to, so we thought we'd come along and share our progress with you and get some feedback from you as well. Lots of the conversation in the working group so far, well, the first conversation as we were starting to talk about the pathway, we had a patient rep who strongly advocated for self-administration as an option for administering these hormone injections. So the next slide, I've got sort of the draft care pathway model for where we are so far. But just to sort of frame it before I get onto that, the primary focus of the pathway is to offer self-administration as an option to patients as the initial option, and then if they aren't able to do that, or if they choose not to self-administer, then they would go through the route that I'm about to show you. So also, just a few caveats. We haven't decided on the preferred drug for breast hormone injection yet, but it will be either probably goserelin or leuprolin. There's benefits and disadvantage to both. Goserelin is a cheaper one, but leuprolin is easier to self-administer. But we're currently going through some cost modeling processes to see which agent would be the best one to move forward to as a preferred drug moving forward. So that's where we are so far. If I go into the next screen, I'm sorry, this is probably going to be really small, so I'm going to zoom in as much as I can. Hopefully you can see that.
That's better for me.
Thanks, Lucy. So just to talk through sort of the draft model as it stands, and just to reiterate, this is draft, so it's not finalized. We welcome any feedback you have on this. I'll just talk you through it as we have. So we begin with the adjuvant early breast cancer patient at the top. They would be reviewed by the oncologist in secondary care, and then, as I mentioned previously, they would be given the option to self-administer as the initial option for the injections. If they choose to, if they say yes, they want to self-administer, then we have a set of inclusion criteria and exclusion criteria, which we've taken from the South East London Cancer Alliance, who have already put together some guidance for self-administering goserelin injections. So if the patient meets that inclusion criteria and doesn't meet the exclusion criteria, then they would then be referred for an assessment and an education appointment by a trained nurse within the trust. I've got here that a patient is provided with sharp spin that might move to a different section of the flow at the moment, but that's by and by. And then if the patient has successfully completed the assessment, dates for the self-administration would be agreed with the patient and the carer and the nurse when the patient collects their medication. And then the first dose of the injection would be administered in the usual setting. So that would be the chemo day unit or the clinic, and or one dose would be administered by the patient carer under direct healthcare professional supervision. Again, that would be in secondary care. Just jumping back up, if the patient chooses not to self-administer, or they don't meet the inclusion criteria, or they don't successfully complete the assessment, the consultant would then initiate the treatment summary plan and the GP letter. And then the patient would start the hormone injections. Again, the first injection would be given in secondary care. I've got here in brackets that there's a possibility of second or third injections taking place in secondary care. It will depend on the transfer time between secondary and primary. But the discussion will take place between secondary care and the GP practice to confirm that they're content to take on the administration of the hormones for the patient, and the summary plan would be shared with the GP as well. The CNS or the other senior other senior nurses discuss the ongoing care with the patient, and then they advise that their GP or the practice nurse will give the hormone injections in primary care moving forward. The patient will then be reviewed in secondary care as required, so they'll remain under the care of secondary care, and continues on the hormones given in the practice or self-administered if they choose to go with that option. They would continue hormones for a period of time, which would be defined by the oncologist, and then the patient would attend the GP practice to receive their injections every month. For a small, the majority of patients will be receiving these injections monthly, but for a small minority, it'll be 3 monthly. But again, that will be advised by secondary care. So that will go on. That pattern will continue until the end of treatment, which usually I think the upper limit is around 5 years for the treatment plan, but the end of treatment will be determined by secondary care. So how we're seeing it is that the patient will remain under secondary care with primary care prescribing and administering the injections. In the case of self-administers, they would just be prescribing the medication on a monthly basis. Just as a sort of add-on to that, I've added a table onto this last slide, just with, again, this is draft, so this may change and it may have edits here or there, but draft responsibilities of how we see the divided responsibilities between secondary care and primary care. So on the left-hand side, the responsibilities of the secondary care clinician, so that would be the consultant or the specialty nurse, a specialist nurse. So they would discuss the benefits and side effects of treatment with the patient and the carer, and they would obtain the verbal consent. They would initiate the injection, so that first injection, including the prescription and administration of the first dose, and then they would monitor the patient's response to that treatment. They would ensure the summary and covering letter go to the patient and the GP to prescribe the injection within 5 working days. They would discuss the concerns regarding the patient's treatment with the GP, provide the GP with direct contact details, and they'd also have some sort of electronic safety netting mechanism in place to monitor and ensure patients are receiving the injections within an appropriate time frame. And on the right-hand side, we've got the responsibilities of the primary care clinician. So that may be split between the GP and or practice nurses. So to prescribe and administer the maintenance doses, and again, that will be in line with the written request from secondary care. To follow the advice in the management plan, unless there's been a discussion and agreement with the specialist team in secondary care to change or modify that. To reinforce and supplement the advice provided by secondary care, and in the event of any adverse reactions, to refer back to the clinician in secondary care for advice. As part of this program of work, we are collating sort of contacts to key contacts to have in place should primary care need to contact someone from the oncology team, or should there be any adverse reactions. We are pulling that information together, and as part of the conversations we're having at the moment is to figure out what sort, and I suppose it's a question for this group as well, is what sort of education needs might there be within primary care to help support this process. There's also responsibility to inform the oncology consultant if the patient discontinues treatment for any reason, to seek the advice of the consultant if there's any concerns with the patient's therapy. And the last one there is to have it similar to secondary care, to have an electronic safety netting mechanism in place. So I've got here that this can be via use of an EMIS template or an EMIS recall method. I think there's some variation across North Central London in what systems are used. I think some practices use EMIS and some use Arden's system. So there may well be others. Please let me know if there are. So that's another piece of work where we want to work with primary care to try to figure out what's the most streamlined and most efficient way of make sure we can track these patients and have a safety net in place without adding any additional work to your plate. So so that's where we are in a nutshell. I apologize because it's a lot of information sort of thrown in your direction, but that's where we're in a nutshell. So yeah, I suppose Lucy, unless there's anything that Lucy wants to add to that, I wonder if there's any questions, comments, or anything that people would like to add to that.
Nothing to add to me. I'd like to give the time to maybe the minute that we have, or a couple of minutes we have, to just hear your views around, particularly around the safety netting, what that pathway looks like for yourselves in primary care, and what education you might have. And if you're not able to share now, you also have Joe's and my email, and we'll be very happy to take that feedback separately too.
Yeah, I'd be very happy to share information via email. So if people need a bit of extra time to digest and take in the information, then they can.
I mean, I just wanted to say, to be fair, as practice nurses, we do a lot of monthly injections every day, and Ardens is within EMIS, Joseph. So we use the Ardens templates within EMIS,
right.
And there's also a safety netting template within there that we can use as well. And also on the monthly injections, it's automatically to put when is the next injection due. So that then prompts our call and recall team. Sometimes they might forget to come in or something. We might have to do a bit of chasing around, but it's not something new to practice. It's something we do already. Some may not be familiar with some of the medications that are giving and may need a little bit more learning on that. But the actual physical thing of giving the monthly injections or 3 monthly injections it's definitely not new to most people in practice.
Great. Thank you. That's really helpful to know about Ardents being within EMIS. I had in my head that it was a separate system, so that's helpful. Thank you.
Thanks,
That's
Frida, for jumping in. Thank you for that. And thanks, Joseph and Lucy, for your presentation. So we have one question in a chat. It says, we had a patient who we used to give monthly Zoladex to, but the communication from the hospital was poor. Will this be improved in the future with a well-written plan? Also, will there be a training provided in how to administer Zoladex or other injections if chosen for the new staff? Because yes, there was, like you said, when the prostate kind of a pathway came into we had kind of training on it. So we need that.
Yeah, so
Yeah.
I think so, Lucy might want to jump in straight after, but I think probably part of the reason the communication was poor is because it wasn't a commissioned pathway, so it was probably happening on an ad hoc basis rather than a formalized process. But the plan is that there will be formal communication in place, and there will be training provided for whichever drug or agent we choose to go forward with as a preferred drug. Sorry, Lucy, I cut you off there.
It's fine. So I just wanted to add to that as well, the other bit about the access to expertise, because say if we're looking at prostate hormones, they're delivered every 3 to 6 months, whereas breast is generally every month. So you need a bit more of a rapid turnaround of that access, and we're trying to ensure that we will ensure that is replicated. But we didn't just want to replicate the steps that we undertook with the prostate hormone work, because I know that for some people the communication might not have been as extensive as it needed to be. There were some issues with the coding and the templates that we had developed. So we really wanted to learn what didn't work quite so well and make sure that we factor that in. And definitely the education we're trying to revamp the cancer pages of the GP website, and in doing so we will have some extra tools and resources on there, but making sure they get the right education out to practice, so that if you're giving these injections you're confident in what you're doing and the effects of the cancer treatment as well.
Yes, so I was going to say as well that obviously the capacity might be the problem, because it's a more often injections once a month for, depending on how many patients you have, that might be a problem in some of the practices.
Yeah, and we are in the process of modelling what that might look like, and what that might look like at a practice level and potentially PCN level. It might be that we could deliver this in a PCN and or maybe federated model. But once we have the more granularity of the data, which has been tricky to get to, we'll be able to share that and just sense check how it might work practice by practice.
Right.
And obviously via an LCS, a locally commissioned service, so there is some remuneration for the activity as well as the education and support element.
Right. Thank you very much. So unless anybody has any other questions, or if you do put them in the chat or whatever, we can always pass it on to Joseph or Lucy as well if anything else comes up. Thank you very much both for a great presentation. Thank you.
Great.
Thanks a lot, Tatiana.
Thank you.
Thanks, everybody. Bye-bye.
Thanks. Bye.
Bye. So we're going to move on now to our lovely Claire Dorrington. Claire, are you here?
Hi, I'm here.
Hi. Right.
Hello.
So I'll floor over to you then, Claire.
Okay, so hi, yeah, I'm Claire. You might have seen me before. I'm a practice nurse at Longgrove Surgery in Barnet and a newly qualified professional nurse advocate. So I work alongside Lisa, our long well-established PNA, and together we are rolling out clinical restorative sessions, individual sessions or group sessions. Primarily the aim with this is to improve the retention and resilience of practice nurses, because it can be quite isolating and people can feel quite lost in it. So we provide sessions in which you can talk about anything. You can talk about if you've got an issue that you want to reflect on, if there's a quality improvement that you want to put in place, if you need some help for your revalidation, anything like that. We're very open. It can be a brief session of just to have a chat about where things are going, where you want to go, if there's any areas that you need to be signposted to for further support, or yeah, just to sort of let things off your chest. We've not had much uptake with this offer, which is unfortunate. I think what I've realized during my training is that in trusts, it's much easier for the PNAs because they can go around to each ward and introduce themselves and talk to people, and they're giving a lot more time than we have available. So we're just trying to reach out directly to any of the nursing staff. It's not just the nurses, it can be the nursing associates, the HCA, just to try and support you in your well-being and in your practice. I think Anissa can probably give a bit more detail about what we've done so far.
Thanks, Claire. And as somebody who has used the wonderful service myself, just to get things off the chest when things get a little bit too much, absolutely brilliant. So please, everybody, just go through it, use it, confidential, whether that's a 10-minute thing, half an hour thing, an hour thing. They're wonderful, and they'll be able to kind of help your well-being and help you with any quandaries you might have in your head. Thank you, Claire. So Anissa, give us a little bit more of a kind of that recent evaluation.
Thank you. Can everyone see my screen? Perfect. So yeah, my name's Nisa. I'm the Senior Project Manager on the Nursing Programme for NCL Training Hub. Some of you may have seen my name pop up on some emails, but yeah, thank you all for having me here today. And thank you, Claire, for that introduction. So I'm going to just be talking to you a little bit about some of the things that Claire's spoken about in terms of what the PNA does, and I'll give you a little bit of data to kind of show you what's been happening so far. Okay, so this is just for a little bit of context. So as you know, there is a NHS staff survey that tends to occur, and in 2018, this identified around 43.5% of those reporting feeling unwell due to work-related stress. A version of the PNA program actually already existed for midwives, where they had noted that there was successful implementation of this program enhancing staff well-being. And following on from that, in 2021, NHS England launched the PNA program. So that was trying to support the recovery of the nursing workforce made worse by the COVID-19 pandemic. And that's where we started, and that's where our NCL Training Hub journey begins. So what do the PNAs do? So Claire kind of already alluded to this already, but it pretty much covers most things. It's hard to kind of put it into one bucket, but essentially they are there to provide you with professional support for the health and well-being of you, providing you with leadership and support through advocacy, career and well-being conversations, as well as restorative clinical supervision sessions. And there's been a proven impact in terms of the impact it's had on nurses previously, for example, in the midwife program, as well as the impact that we've actually collated here in NCL Training Hub and how it's already affected nurses within our workforce. So this is just kind of a denotation of more tangible understanding of what the PNAs do. So it's separated into three main categories: clinical, well-being, and learning support. So if we go through clinical, so PNAs act as an advocate for patients and their families. They can create care plans for challenging situations, support you to implement change in different clinical areas, as well as promoting psychological safety. In terms of well-being support, this covers many things. And just to name a few, we've got clinical incidents, team dynamics, stress or burnout, instances of bullying, career progression interviews, quality initiatives, or any personal issues you may have. So as you can imagine, that's pretty much everything. In terms of learning, we've got holding reflective discussions about revalidation and career development, preparation for appraisals, and also coaching staff again through incidents or traumatic events. So it's really important to note that the professional nurse advocates are not there to kind of deliver you like a 1-hour session each and every single time. It's based on what you need. So if you need a 10-minute conversation on a call, if you need a 50-minute conversation over Teams, if you need a face-to-face, all those things can be implemented through the PNA team. So it's not restrictive, it's very open, and it's down to what you need. And so these are some of the benefits I've already kind of outlined in terms of the service. So feeling supported and listened to, experience less stress, burnout, and absence, develop personally and professionally, less inclined to leave the profession. And a really important key part is actually a P&A session counts towards CPD. So that's important to know for yourself as well as for your organization if you're requesting, time off to attend a P&A session. So yeah, really, really key to know that. So this is just an example of some of the groups of the nursing workforce already that's been touched by the professional nurse advocate team in NCL. So we've got GPN trainees, nursing associates, fellows, borough nurse leads, PCN nurse leads. Like Claire mentioned, it's not restrictive and it covers the most of the nursing workforce. So they're here for you. So these are just a couple of outlined examples of reported impact from the P&A team so far. So I'm just going to read you through some of them to give you an understanding of what kind of changes have already been noted. So we've got nurses feeling more supported with challenges as and when required. Nursing teams starting to create change in practice by changing appointment times and recall processes. Early signposting for burnout, bereavement, mentoring and career progression opportunities. Nurses feeling confident to speak up and in some instances setting up protected time for education and support sessions for nurses in their PCM. Nurses feeling empowered to apply for leadership roles and being aware of the opportunities that exist. And nurses feeling more confident to voice change in practice and being involved in conversations at practice at PCN level. Now, these are just some of the examples, all coming off of a P&A session. So as you can tell, it really does cover a wide breadth of opportunities as well as kind of areas where you can discuss and take forward into actual change in primary care. So this is just a little bit of our data, and this is data that's been collected over the last year in terms of the kind of access of support. So a lot of these things I've already mentioned, but really it's just to highlight, for example, what is the support you receive from a professional nurse advocate. Now, there was a majority of restorative clinical supervision sessions, but it's not restricted to that. And you can see we have a lot of quality initiative improvement support, as well as career conversations. The graph to the right hand side, what's the reason for seeking support? I've already gone into a lot of the reasons why someone would seek support, but again, it's just to show you the breadth of different kind of options and availability for accessing a P&A and what that can provide you. We've got needing clinical advice to work related stress, to personal stress, to career development. The list is really endless. Okay, and this is a little bit more data in terms of the direct impact it's had. So the graph to the orange graph on the left. So did the support you receive, so that's the P&A support, improve your well-being and prevent you from going off sick? And out of the feedback attendees, we had 43% of them saying that it stopped them from needing to go off sick, which is an amazing statistics given that this is purely coming off of a session with a P&A. The blue graph, did the support you receive help to make you a safer practitioner? And an overwhelming 63% said that that did, which is really, really great. Did the support you receive help retain you in your current role? And a staggering 70% said that did. Now that's really, really key and important, and an amazing statistic of what the P&A impact really does have. So yeah, really crucial. And again, would you recommend professional nurse advocate support to your colleagues? And yeah, 100% said yes. So, I mean, it's a no-brainer. There's no reason why, anyone shouldn't access it. It's more, why haven't you accessed it really? So please use the support. It is really there for you. I have two videos, really, really short videos of a case study. I'm hoping it's going to play. Maybe it won't. Yes. Okay.
Hello, my name's Samantha. I'm a nursing associate at St Peter's Street Medical Practice in Islington, and I had a session with the P&A just as I was about to qualify, as I was having a bit of a personal and professional crisis. It was really a really nice safe space to kind of just air out what was going on, how I was feeling, what I was thinking, and just have some unbiased professional support and somebody to be able to see my point of view and help me talk things through and allow me to explore and come up with my own decision that was right for me at that point in time. I would really highly recommend a session with a PNA, no matter what the issue is, just a safe place to speak out and share ideas, thoughts and feelings with someone who understands.
Sorry about the buffering. I've got one more video, and again, it's just a case study of someone who has also attended a PNA session.
Hi, my name's Carl and I'm a nursing associate at Parliament Hill Medical Centre and the PCN Nurse League for Kentish Town Central. The P&A sessions have been invaluable to me in terms of developing my career and my leadership skills. Because of the P&A sessions, I think I'm the first nursing associate ever to become a PCN nurse lead, which is something I'm very proud of. The sessions have also helped me develop my clinical supervision skills and through mentoring during the P&A sessions, it's enabled me to decide on my career pathway, which is looking like to be the advanced care practitioner pathway. In terms of benefits in my day-to-day practice, the sessions have been a safe space for me to talk about any issues at work in confidence, and the sessions have also helped me develop my current knowledge and skills as a nursing associate who's transitioning to becoming a practice nurse. I don't think my self-belief and confidence in my own ability would be anywhere near the level that it is now without the P&A sessions. I really value them, and I hope that more nurses benefit from.
Sorry guys, there's a little bit of technical issues there, but hopefully you got the gist of what I was really trying to put across, and how important it is really to access the P&A. I'm going to pop in the chat the emails of both Claire and Lisa, as well as our general P&A chat if you'd like to request a session, and please feel free to ask any questions to either me or Claire now, or take this outside of the meeting. Thank you so much.
I just want to quickly add, because I forgot to say it in the beginning, but and they mentioned it in their videos, is that it is a confidential space. So what is said in those sessions, in those bits together with the P&A, is kept there. Okay, the only time anything would go beyond that is if there was obviously an issue of safety, but then that would be discussed. So these are safe, confidential spaces. The employer doesn't know anything about what's going on, or NCL or anything like that. It's between the person and the P&A. Okay, just because I think that might hold some people back. Okay, thank you.
Great, thanks, Claire. Message received loud and clear. Thank you. Yeah, and thank you both, Anissa and Claire. For anybody has any questions on the role, or would like to say anything, or even give some of the feedback how it helped them if they use it. No one. Okay. Well, I most definitely find them helpful, because there were days when I hit the wall, and I'm not quite sure if I would have been here today if it wasn't for a great big chat that I had with them. So yeah, very, very helpful. Thank you. Sounds like something I could use at the moment. Okay, so I think Anissa will pop an email. It's extremely helpful for me as well, Liam. Yes, thank you. So we'll pop an email or a link where we can where you can access this, but it's all on the NCL Training Hub website as well, so it's easy to get to. But we'll pop it here in the chat as well. Okay, so if nobody has anything else, No sessions are that they can be, like I said, on a phone call, on a Teams call, face to face. You know, however it suits, you can contact and then make that plan with the TNA. Anissa?
Hi, can I also just say, if we're not able to use this service, it's potential that we might not be able to fund it further. So it's really important that this service is there right now, available to you. So please use it. Otherwise, if it's not used, it's not something we're going to be able to continue using in the future, which is really, really key. Thank you.
Especially with all the great data that we've seen, how he has helped the nurses that have used it, how well he has helped them to kind of not leave the profession and help them in their well-being. So thanks, Anissa. So if there is nobody else, so I can see the Anissa's popped down email addresses, so that's great. So we might then move on to our lovely Mentimeter to get a little bit of feedback from you as to how you're finding these forums, what else you would like to see on them. So Barbara, are you going to be able to get that up and running, please?
Yes, bear with 2 seconds.
Thank God I don't have to do that.
Okay, sorry, bear with me. Can everyone see my screen, or is it not sharing just yet?
Not sharing
Not
yet.
sharing.
Okay, sorry.
There are a few gremlins in today. I had to come out and come back once already, so
I'll just do it this way. Can you see that?
yeah, we can see that now.
Amazing. Okay, so I'll just move on to the next screen, which will show the instructions on how to join the Mentimeter. So if you have a phone, or if you want to use the current PCs or laptops that you're on, you can scan the QR code, or you can put Mentimeter into your search bar and enter that code to join the session. And when you eventually do, there's an option to give a thumbs up so we can know that you've joined. I think we've got 45 people in this call, so maybe let's aim for a minimum of 30. We've got 12 people so far.
Getting there slowly. If you do a little thumbs up on the actual Mentimeter as well.
Yeah. Amazing. Amazing. So we'll get to 30, but in the following slides, there'll also be a QR code that people can scan in the middle of the feedback session. So if there is anyone that's late to join, there is a way to still do so. Can we get 5 more people in the call? Yeah.
Let's push.
Just be sure to do a thumbs up once you've joined, guys. Okay. No movement. Do you think it's best to start, Tanya?
Yeah, might as
Yeah.
well get going,
Okay.
and anybody can kind of do it.
Amazing. All right.
Thanks, guys, for putting into the chat as well. Thank you.
You want me to talk through this one time? So the first question is basically, which borough are you based in? So yeah, it'd be good to know where the attendees of our call and what borough you're based in. I know we've got 24 people on Mentimeter right now. So that is,
Getting there, 26 now.
yeah, 26. No, there's one more person. Okay, perfect.
Okay.
We'll move on to the next slide. Okay, what is your job title? So it'd be good to know the range of professions that we have in the call. So if you could just input what your job title is. Practice nurses, HCAs, nurse educators. Good to see a range. There are nurse leads. Amazing. Ah, 30 responses, nice. Okay, we'll move on to the next slide.
Okay. Yeah, so we're here kind of looking at the extent to which you agree or disagree with the following statement. So if you hover over it, that's how it works?
Yeah, so you'll have like a little slide where you can read the statements that we've got here, and then you can choose as to what extent you agree or disagree with them. And we'll kind of have an average once we've got enough responses. I don't know if we want to go through each of the statements. So we've got overall, I'm satisfied with the topics covered in the NCL nursing team forums. Overall, I'm satisfied with the frequency of the NCL nursing team forums. We've also got, I'd like for the NCL nursing team forums to be more interactive. So that would include more participation from our attendees, maybe breakout rooms for smaller discussions. And then we've also got, I would be happy with the NCL nursing team forums being opened up to include other professional groups in the future. It'd be good to know your thoughts on this. We've got 25 people that have responded, 26 now. Can we get a few more? Amazing.
I think we got there, haven't we?
Yes, okay. The next question is, what determines your attendance to the NCL nursing team forum? So we've only really got two options here. So is it the availability on planned date and time? So as you guys know, the forums happen on the third Wednesday of every month, apart from the months where there's high holidays, so December and August. Or is it in regards to the topics that are covered in the agenda? Would that determine whether you choose to attend or not? Kind of looks like it's in terms of availability, so it's good to know. Great. Okay, we'll move on to I believe it's the last question. So what topics would you like to see covered in future forums? So I know currently what we do is we have kind of system updates or maybe updates in regards to referral pathways or services, but we also have bite-sized training sessions as well. So it'd be good to know what everyone thinks or what everyone would like to see in future forums so that we can kind of use this to try and build and plan for our future sessions. Diabetes, wound care, HRT, menopause. Yeah, quite a few HRTs. Good to know. Amazing. This is really useful, guys. Thank you.
Quite a wide range of topics, which is
Yeah.
fantastic to see.
Yeah.
And not all clinical, which is as well interesting as well.
Yeah,
Fantastic.
yeah. Got 24 responses. Maybe we can get some more, but this is really, yeah, it's really useful information. Training system changes that impact the nursing role, retention reviews, changes in nursing structures, government plans. Amazing. Yeah, and you can also put more than one, I should have mentioned this, you can put more than one topic, guys, if you have more. Okay. Tanya, this is the last question. Maybe I can leave it up there so people, if the people are still thinking, they can put some things in. But yeah, that was the last question for that feedback form.
Fantastic, brilliant. Well, I think we have a lot to look through and think about and use for planning for future sessions as well. So thank you very much for these great suggestions, everybody. So unless anybody has any questions about anything we chatted today or would like to say anything or add anything, we might be able to give you a few minutes of your lunch back then. So as I said, there is going to be no session in August because we tend to be mostly on annual leave. So usually August and December, we don't tend to have forums, but after that, September, we kick off again. So we'll be in touch with all the dates and the agenda for all of you in the newsletters. So
yeah, it should be the 3rd Wednesday of September. So I believe that is the 18th of September. So yeah, we will see you all then. I'll stop sharing my screen.
Excellent. Right, well, thank you very much for coming and for sharing this fantastic feedback with us. Finding very, very useful. And have a lovely, lovely summer, everybody. Don't work too hard. Do try to rest and look after yourselves as well, and book in with PNAs. They can help. Okay, nice seeing you all. Take care.
Thank you. Bye.
Thank you.